Hey guys, Ryan Bodwani here, one of the chairs of the Young Innovators.
And
Today,
also Godfrey, one of the chairs.
thanks, sincere. So we're going to give it about a minute or so, just so that everybody gets a chance to hop on, and then we'll get started for the talk. All right, everybody, we'll get started tonight. So welcome to the Young Innovators webinar. Our goal today really is to talk about board preparation and continuing medical education. So as young innovators, we kind of struggle because, we've just finished our training. We've, hopped on to really the horse race of becoming an attending and what it means to really deal with all the changing technologies in our field. Every day there's something new, there's something that's coming up, and we have to try to keep up with that. So that can be a struggle at times. And back at ASPN in our meeting in July, which was really well attended, Nasir and I started talking about, what can we do to make this more of an educational based platform so that our members have better access to it. And so at that point, we started beginning talks with Dr. David Rosenblum from Pain Exam, who's going to be working with us on this webinar tonight to really discuss, options to basically better train in this field. Not just that, but how to actually get the core content that you need to do well on throughout your fellowship, and then also throughout your training as an attendee, and also to continue to get that continuing medical education. So I'm going to hand this off to Nasir briefly so you can kind of go over the agenda for tonight.
Thanks, Ryan. Those were our disclosures for CME purposes. Again, as Ryan said, I think this is going to be a really informative, really educational, and really a worthwhile endeavor for us tonight. We're going to spend about 10 minutes kind of just going over the overview with Dr. Rosenblum about the pain exam itself for board purposes. We're going to spend about 10 minutes talking about our first case, which is about abdominal pain. That's going to be a discussion that's led by Dr. Rosenblum. We're going to have sort of a panel discussion. I know it says practice questions, but really it's going to be more of a panel discussion with Anuj Shah and Vinny Francio. Anuj is currently a resident. Vinny's one of the fellows over there at the University of Kansas. And so we're going to spend about 10 minutes doing that. We're then going to go on to a different conversation. We're going to be talking about knee pain and all of the challenges and sort of different, aspects to that. That's then going to be followed by a panel discussion again with Melissa Murphy and Yusra Ibrahim, both of whom are actually practicing physicians. So we'll kind of hear a different aspect and viewpoint there. And then finally, we're just going to talk a little bit about some tips and tricks for studying for the board exam for pain medicine. And that's going to be a little bit of a panel discussion with kind of all of us who are here on this webinar tonight as moderators and as panelists, and then just a little bit of closing remarks at the very end. So we're very much looking forward to this.
Perfect. So, this is just a brief introduction for Dr. Rosenblum. So basically, he's been working on the pain exam platform, which is really the goal is to educate fellows and residents, and hopefully, young innovators, people that are in the first, 3 to 5 years of, their field, on what the latest topics are, what the core content is. And he's developed this entire broad platform. Not just that, he's worked to kind of develop the ultrasound content as well. And I've had really the pleasure to attend some of these sessions with him. And I think there's really quality content that's available there. And we're really honored that, he's been able to partner with us. Hopefully this is the first of many webinars where we're going to be able to provide this kind of access and content to our presenters. So I'm going to hand this off to Dr. Rosenblum for the next portion of this talk.
Thank you, Ryan Nasir, and thank you, Aspen, for the invitation. It's always nice to be part of something bigger than what I'm already doing. So, Lakin, if we could please proceed, I'll get into the various. Well, before that, those of you who are claiming CME credits, my hospital is offering them. Just text the term 45 SPEC to 828-295-1144. And if you missed this, it's going to be broadcasted towards the end of the webinar. Okay, so the ABA pain medicine examination, as you can imagine, has a wide range of content ranging from the assessment of pain. All these scales that you're probably not using every day in your practice will be on the test. Pharmacotherapy, of course, the different procedures, more heavy on fluoroscopy. However, I wouldn't be surprised if every year ultrasound is having a stronger presence on the boards. Now, I did ultrasound practice questions back since 2008, and every year people tell me there's really not much ultrasound, but I anticipate it's going to appear more and more. The various types of pain syndromes, musculoskeletal pain, cancer, non-cancer pain. If you look at the actual syllabus and outline, you go to the next slide. It goes over the ethics and the cultural considerations of pain, the epidemiology of pain. I mean, you could take this to so many different levels. And the pass rate in 2020 was 83%. The exam is 200 multiple choice questions. It's a 4-hour exam. And the background concepts consist of 5% of the pain, assessment of pain. Those tests are about 5%. Pharmacotherapy, 15%, procedures, more common, 15%, psychological aspects, physical and integrative therapies, 10%, and clinical states. I mean, the various types of pain problems, they're asking you to make a differential or come up with some treatment. That's going to comprise 50% of the exam. The ABPM has certified over 2,200 doctors in pain management since 2022, and the pass rate is about 75%. There's 400 multiple choice questions. The exam is divided into 2 4-hour sections, and the topics are pretty similar to the previous. Anatomy and physiology and comprise a large percentage, 15%. Diagnostic testing, 11%. Types of pain, 12%. Assessment, 14%. Pharmacology, 16%. And interventions, 15%. Psychological aspects of pain, it's always present. Do not discount it. They also go over compensation, disability, and medical legal issues to a lesser extent. The ABIP is a certification exam. It's an exam that people who may not have done a fellowship may sit for. There's 2 parts. Part 1 is the theoretical written exam, where they cover anatomy, physiology, 10%, pharmacology, 10%, psychology, 5%, assessment of pain, 5%, diagnostic testing. Various pain syndromes, as you can imagine, interventions have a larger percentage of presence on the exam. Non-interventions, 10%, and coding compliance, which you don't see as much on the ABA's exam, is present in 10%, as well as controlled substance management and ethics. The second part is a practical examination, and it covers anatomy, physiology, pharmacology, psychology, assessment of pain, diagnostic tests, pain syndromes, interventional techniques, non-interventional practice techniques of pain, and of course, coding compliance and controlled substance management. The World Institute of Pain, the FIPP, also has an exam. This exam is unique. It has 3 parts. Part 1 is the theoretical exam. It's 104 option multiple choice questions. The examinees will have 2 hours to respond, and it goes over general knowledge, cancer pain, chronic pain, visceral pain, neuropathic pain, headaches, all the various body parts, the pain procedures that we typically will do for these patients, and much more. They also go over radiation safety. Part 2A is the practical exam, and Part 2B is the oral exam. This is quite extensive. 2A, you're doing 4 procedures on a cadaver in the presence of 2 examiners. You'll have 15 minutes in which to perform each procedure with a C-arm. 2 examiners with the assistance of a C-arm will evaluate the physician how they're doing it, and then there's also an oral component. It's okay, you can advance. So in 2B, you're getting questioned on by 2 examiners on 2 separate cases. The examinees spend up to 15 minutes on each case. You get 5 minutes to review the case history, and then you get examined or grilled by the examiners on the diagnosis, the workup, and of course the intervention that should be performed. They'll ask a series of 10 questions that relate to the care of the treatment of this patient, and the session could last for up to 15 minutes. And then you do the same thing with the second examiner. You have to go over your diagnosis, your suggested intervention, and as with any oral exam, especially if you've done your oral boards away, you need to be able to defend yourself against not what you're doing, more of the why and how you're going to handle any complication, and explain your considerations of what could go wrong with each procedure. Okay, so the first case, as the second one, they're both patients from my practice, which I thought had a lot of great teaching points and were very interesting cases to review. This was a 19-year-old female who presented with 8 out of 10 right lower quadrant pain radiating to the pelvis. It was dull, achy, worse with movement. Had a gradual onset, it's been present for 2 years, it improved with rest, and it also improved for 2 weeks after both of the 2 surgeries she had below. Past medical history is non-contributory. Surgical history was appendectomy and X-slap, all during those 2 years. I think that the physicians she saw really didn't know what to do with her, and they were trying to figure out ways to evaluate her for pain. They figured that she may have endometriosis. They treated her with ibuprofen, didn't really do much. No significant history for drugs or family history or alcohol abuse. So when we're thinking differentials, and any of the panelists, feel free to chime in here. Well, she presents with abdominal pain, so of course you're going to think of gastrointestinal pain. Reasons possibly. So when you think gastrointestinal, the first thing you think of is somatic versus visceral, and there are ways to distinguish this on the history as well as the physical exam. Somatic pain is basically pain of the muscles, the nerves, the fascia, whereas visceral pain is the bowel, right? So visceral pain may be something more like the feeling you have when you have a lot of distended viscera from gas, for instance, or you need to use the bathroom. And somatic pain is more like the pain you get in your abdomen when you did too many sit-ups. Urogeneral, GU, could be a stone, could be a gyne issue such as a cyst, ovarian torsion, something like that. Musculoskeletal, there's the rectus muscles, there's obliques, there's muscles all over the place in the body. And of course, nerves. It could be a thoracic radicular entrapment radiating down to the lower belly wall. And with any patient, there may be an aspect that's psychological, such as somatization, which is a tendency to experience psychological distress in the form of somatic symptoms, and to seek help for these symptoms. It can be initiated or perpetuated by emotional responses such as anxiety and depression. Then there's also the conversion disorder. It's a psychiatric disorder, signs and symptoms affecting sensory or motor function inconsistent with patterns of known neurological diseases or other medical conditions, and significantly impact the patient's ability to function. For instance, the patient sees somebody get injured in a motor vehicle accident, and then they just watch it. They weren't there in the actual car, but because they can't move their leg, something like that. Secondary gain would be maybe somebody who is exaggerating their symptoms for compensation to get out of work, to get more attention from a spouse, etc. So in mentioning this, I wanted to mention another syndrome. This is something that is a great boards question, but I've probably only seen it a couple times in my practice. And this is the abdominal cutaneous nerve entrapment syndrome, very testable for the boards. And I have seen it on the boards actually. Peripheral nerve entrapment occurring where the nerve changes direction, okay? As it enters the fibrous or osteofibrous tunnel, it passes over a fibrous muscular band. The most common location is at the lateral border of the rectus muscle. When you ask the patient where the pain is, they'll find one spot on their abdomen, and it's typically the lateral border of the rectus, and you could diagnose it by giving a little local anesthetic with steroid. It can reduce inflammation, and ice can also help. You can also put pressure, an elastic band on the abdomen for counter pressure, which may relieve symptoms. And sometimes heat may be helpful for muscle spasm associated with the syndrome. Endometriosis is something that they love to test as well. It's a chronic estrogen-dependent condition characterized by ectopic implantation of functional tissue lining the uterus, basically endometrial glands outside of the uterine cavity. 10 to 15% of women reproductive age may have this, but if someone has pelvic pain or chronic pelvic pain, there's a 70% chance that they may have this. When ovulation occurs, it's followed by inflammation, release of cytokines, TNF-alpha, IL-1, IL-6. It enhances cell proliferation, oxidative stress, and leads to increased production of leukotrienes and prostaglandins, hence pain. Laparoscopic examination is the gold standard with biopsy, and treatment includes NSAIDs, progestins, and combined hormonal contraceptives. I actually have a patient who has this, and she also has somatic pain as well, and she'll come in once or twice a year and she says, hey, it's endometriosis, and we put her on meloxicam. Or she'll say, you know, it's that other problem in my belly related to the surgery I have, and we'll give her a tap block, and she does great. So on this patient, she had right lower quadrant tenderness. She also had some right lower back tenderness, Motor and sensory were intact. She did have some pain radiating to the groin and anterior thigh a little bit. Her straight leg raise was negative, but it did provoke a little back pain. SI joint was non-tender, Faber was negative. So what else are you thinking of? And I'm going to let the panelists get on and chime in. I mean, this patient had appendectomy, endometriosis, and for some reason, each time she had surgery for 2 weeks, she had a resolution of her symptoms. Well, you could always say, well, they probably gave her opiates after surgery, right? So painkillers, that's the most obvious reason, but maybe there's another reason. And as an anesthesiologist, I had a few thoughts, but on exam, she did have some active hip flexion and pain on passive extension. So guys, what do you think may be a player here, or what would you want to know about this patient?
Yeah, I think, no, sorry, go ahead, Minnie.
No, go ahead, Anush.
I just want to know patient's activity level, figure out, athlete or any trauma, and sort of figure out, if they are athlete and thinking more MSK pain, and start taking a closer look at that specifically, especially with, a relief of pain with rest, and then some of these physical exam findings make me a little bit suspicious for MSK stuff.
Absolutely. She was somewhat active. I wouldn't say she was on these sports teams, but she was a pretty active child or young woman. And the pain was limiting her ability to do activities for 2 years. So she wasn't very active with that. Lakin, could you advance to the next slide? So imaging was done, which was negative. She had an appendectomy. Ultrasound was negative. X-rays were all negative. I mean, one thing, she had an appendectomy. That the appendix line is very close to a particular muscle, right? Maybe that's a clue. I don't know.
Yeah, so I think giving the history of appendectomy is certainly something important to consider. You want to go back to your anatomy and try to remember what nerves are in that area. What is the relationship of adjacent musculature? I agree with Anush that the fact that the presentation was mechanically driven, rest, changing in positions, things like that, does point towards the MSK aspect, and you kind of keep that in mind as higher in your differential. But I think the workup that you presented, kind of going over the, in this case, female pelvic anatomy differential, visceral, looking at in GI, GU, bladder, I think all of those particular thought processes are essential for us to have as we advance our careers in fellowship, like I am right now, and as I kind of do that thought process preparing for boards. I think that's important to have, and I think it's important to consider in her case that you're presenting the importance of physical exam, since the imaging was negative, right? What am I going to look in terms of physical exam? Maybe I want to poke into that area that is hurting and move the spine around, move the lower extremity around, and see if I can provoke that symptomatology. I think that can give us a lot of valuable information.
So she, during that 2 years of suffering, she went through every specialist you could think of: GI, GU, GYN, even psychologist, I think, the whole 9 yards. I examined her. When she said about the surgery alleviating her symptoms, I immediately thought as an anesthesiologist about muscle relaxants. We give muscle relaxants for surgery, for intubation. Maybe there's connection, who knows, maybe no connection at all. But I started to provoke the psoas muscle. I asked her to activate it. I had her flex against pressure, extend it passively, and that triggered her symptoms. And the psoas muscle runs from the upper lumbar, basically through the belly to the pelvis, to the lesser trochanter. So that made a lot of sense, because she had groin pain, right lower quadrant pain, back pain with some radiation to the anterior thigh, and there are nerves running through that muscle as well that can do that. So this is really a rare injury that can be seen with runners, dancers, high jumpers. I once had a patient who I was treating for a bit, and it wasn't until she kept saying the physical therapist made her repetitively flex her hip with a weight on her foot over and over that I then pivoted from doing an epidural to the psoas injection, which got her better. So this can also be related to bursitis, and the term can be interchanged with iliopsoas tendonitis, internal snapping hip, or iliopsoas impingement. So you could do various maneuvers to check for this. Ludloff test is one of them, and the patient's seated. You have the knees extended. They lift their heel of the affected side of the table. Any weakness or pain is considered positive, or the snapping hip sign. And Lacken, you could play the video while I reads the text, please. So basically, he's having the patient flex their hip and externally rotate it as they abduct, and then they put it into hip extension with a low internal rotation. They're trying to get the tendon to basically snap over the acetabulum and reproduce symptoms. And this could be suggestive of the psoas sign, psoas syndrome. So with this patient, you go to the next slide. I wound up sending to physical therapy before I did any injections, and she disappeared. And this was a unique case. Not too many 19-year-olds walk into my office. So I called her mother a few months later. I said, "Hey, what happened?" And her mom's like, "Yeah, physical therapy basically cured her after 2 years of suffering, 2 surgeries, meds, multiple specialists." So treatment is typically physical therapy, right? Or rest. If that doesn't work, then we break out our tools: the meds, the NSAIDs, muscle relaxants, and the injections, of course. Next slide,
Or
please.
use those to, help with physical therapy itself. I think that's important. So it's crazy she never tried physical therapy before the whole time until that point.
Might have, but I don't think they were targeting the psoas muscle.
Right.
I don't know doing physical therapy, but they definitely weren't looking at this muscle. I'll tell you that.
Working on it, yeah.
So basically, here's an image of the psoas muscle. Now I attached an MRI image because I want you to see how thick the psoas muscle is. And if you just click once, it's going to point out the psoas muscle on the MRI. There you go. And the way I do this injection is actually a little different than the middle one. If you notice the middle picture, it's a nice image of the psoas. It's an accurate shot. However, the way I was trained, the way I do it is I actually advance the needle further to the distal 1/3, 2/3 border of that bone, of that vertebral body, usually around L3 or so. And I find that it works well, but it looks like they got the muscle here, so I can't really criticize much. Do you guys have anything to add to that case before I move on?
Nothing for me. I think you went straight through looking at the visceral pain causes, somatic, and going all the way through MSK. I think that's the way we had to break it down. Rule out emergencies, rule out things that can really harm the patient that aren't taken care of acutely. Obviously, this patient had 2 years of pain, so it's a little bit different. But in a different setting, a different acuity, we want to rule out the emergencies.
Yeah,
Okay,
absolutely agree 100%. I think it's so easy, and for us, you forget, to look into the other stuff, and as you were discussing this, I was thinking about the other anatomy in that area. So, stress femoral fracture, that was really never, like obviously you'll see that on an MRI or on a CT scan or X-ray potentially, or a vascular necrosis, but those are some of the things that can present with pain in that area. So it's always something to kind of keep in mind, that right lower quadrant pain may be abdominal, may be pelvic, but obviously keep in mind your spine pathology, your SI pathology, your hip pathology. So it's easy to forget sometimes. So it's a good case reminder.
Thank you. Okay, so this case was a little bit more of a challenging for me, at least, because it seemed very straightforward. It wasn't. So we had an 81-year-old female. This is actually a patient I inherited from my partner who retired. Low back pain radiating down the anterior aspect of the left thigh to the knee, hypertension, cholesterol. She had a knee replacement 1 year prior to my taking over the case. She was on metoprolol, simvastatin. So first thing, I see this slide, and the first thing that calls out to me is the statin. Can you please click? So statin myopathy can appear on the boards. It's just a little pearl here. And it presents as myalgia, myositis. It could be even rhabdomyolysis, asymptomatic increases in creatinine kinase, or symptomatic. And the treatment is basically discontinuation of the statin. And it's just something just to be aware of in your practice as well as on the boards. Okay, so patient had the total knee arthroplasty, and she had basically knee pain, which did not get better after surgery. She also had this on and off back time. Some exams had her having some symptoms, some of them didn't. She always reported pressure in the back, achy legs, numbness over the left knee since the surgery. It was constant and debilitating. Ranged from 5 to 7. There was no weakness, but she did have problems changing position. And the pain was improved by leaning forward, which goes along with possibly spinal stenosis, which you expect in her age. She was on gabapentin, Celebrex, which didn't really do enough. She tried prednisone, tizanidine, meloxicam, minimal relief, PT. She's had epidurals in the past of varying relief from her lumbar disease, which she had lumbar disc disease, degeneration. And she had a left knee replacement and basically didn't really change her pain. In fact, it was worse. On exam, her left knee was tender. Her back was symmetric. Some days it was tender, some days it was normal. It really depended on when you caught her. SI joint negative. Range of motion of the spine was fairly normal. SLR negative. And in case you forgot, these are the normal ranges: flexion 50 degrees, extension 15. I've seen variations in other texts: 20 degrees right in lateral flexion, 5 degrees with rotation. On the X-ray, the hardware looked fine for the knee. On the imaging, she did have L2-3, L3-4 issues: stenosis, facetharopathy, L2-3, a disc protrusion at L3-4, L4-5 for amylostenosis, which could definitely cause pain to the knee, right? So it was reasonable to offer this patient an epidural, which we did, but it didn't really do the job. Incomplete relief with spine interventions. You could argue, all right, well, just send her to spine surgery or do a mild or discectomy or something. But she had this real tender knee with a lot of pain and allodynia, pain and range of motion. So, and on exam, that knee pain became more apparent. Okay, so first of all, I guess before I get into the, what would you guys do before we move to the next slide? Don't want to give it away. What are you guys thinking?
So I think you've ruled out the back as much as you could. You've gotten the appropriate imaging. I think it's important when we're looking at these patients who have knee pain and have had surgery, not just to have tunnel vision on the knee. We know that a lot of different sources of from the back can cause pain. So whether that's spinal stenosis or facet arthropathy or even SI joint arthropathy, all of that can cause contribute to the pain. I think with her, you tried multiple transforaminal epidurals, which didn't really provide her much relief. And now she has allodynia over the side of the knee. One of the things that I've actually seen a few times after knee surgery is infrapatellar saphenous neuralgia. So just even given how they do total knee arthroplasties, we know that multiple nerves get damaged during the surgery. So that's something that I would maybe target and go after, either by doing a diagnostic block targeting the saphenous nerve and then maybe proceeding with peripheral nerve stimulation.
Yeah, great. And thank you so much for a great case, Dr. Rosenbluth. So I'm in the ortho group, so I see a lot of these post-TKA knee patients from just my ortho surgeons that send over. It's amazing how just the different presentations. So I remember there was one patient who came in, I think which is 4 weeks after TKA, severe pain in the knee, hot. You can't even touch her. She was in crutches and she can barely walk and can't put weight on it. And my ortho surgeon would say, this is way beyond what I would expect of 4 weeks after TKA. This is not normal, you know, actually looks great. The hardware looks great. Everything is appropriate. It just, the pain is too much more than what I expected. So I think we need to try to think about, is this neuropathic or is this a nociceptive? Is this a mechanical issue or is this a more of a nerve kind of condition? And also your presentation, you mentioned that she had pain before the TKA. So typically I ask them, how was your pain before the knee replacement and how is your pain after knee replacement? And some people will say prior to TKA, it was more mechanical, and after TKA, it's more sensitivity, nerve. It's just a different kind of pain. So I think we're on the right track, right? So go ahead.
Okay, let's advance. Okay, so I basically threw the kitchen sink at this patient. Transforaminals, interlaminars, then we moved on to the knee. Deep geniculars were positive ×2, RFA, no relief. Superficial geniculars, I went after the femoral, anterior femoral cutaneous nerves, the infrapatellar saphenous nerve, and then I cryotherapy these nerves, cryoablated these nerves, no relief. So I said, okay, well, what's left? PNS, peripheral nerve stimulation. So I'm not sure if we could mention companies, so I'm just going to say I use the 2-month device. And the 2-month device, the day of this, I was planning on putting 2 leads for the knee. One was going to be a genicular, the other was saphenous, but she just was not stop complaining to me about her back. So I have 2 options with this device. So I had one lead go to the multifidus on that side. The other lead went to the saphenous and the adductor canal on that knee. And the back pain dramatically improved over 2 months. The knee pain, minimally improvement. So what's left? Any ideas? What would you guys do at this point? DRG?
I would do an LSV,
DRG.
a sympathetic block at this point.
Anything else?
Neuropathic pain medications, gabapentin, Cymbalta.
For those, she had
SAC.
those.
Yeah.
The lighting patches, the Lyricas.
Physical
Okay,
therapy, make sure that was done too. Yeah.
I agree with you, and that's exactly what I did. Lakin, go to the next slide, please. So this is what actually finally helped this patient. And I'm reassessing myself because I remember almost every time I examined her leg, she had some allodynia and hyperalgesia, but because she was elderly and she had a knee replaced, and I've done a million cases where this happens, I do my geniculars and they're happy, I kind of put the sympathetic block all the way down the chain as to where I would go. So I'm criticizing myself. I probably should have done this a lot sooner. But you know, they say what's common is common. It just doesn't always present in a common way. So I suppose you would classify this as either a CRPS or a causalgia. I mean, you know, they went through nerves and probably they went through the infrapatelosaphenous, maybe some geniculars. But either way, she had 2 lumbar sympathetics and it tremendously helped her. And I feel bad she was suffering for so long until we got to this point. But it is what it is, right? At least we got here. Anything to add, guys?
So there's interesting statistics. On average, by the time a chronic pain patient presents to a pain specialist for CRPS, it's usually 18 months later. On average in this country, it takes 18 months for a CRPS patient to present to a pain clinic, which is really sad and impressive at the same time. So I think it's really important to have early diagnosis because a lot of these patients, they do better with early diagnosis. The sooner we diagnose, the sooner we intervene, and the sooner, the better they do. I've seen some patients, their CRPS is essentially gone after 1 or 2 LSVs, just like what you mentioned.
That's right. When you hit it early, it's higher cure rates. So, okay. So just to review the basics, genicular nerve has about, I think there's something like 17 nerves that innervate the knee. You have a lot. We're really dumbing it down here. Okay. We go for the 3 major, most of us go through the 3 major branches: superior medial, superior lateral, inferior medial geniculars. Never do the lateral geniculars because of the risk of a foot drop if you get the peroneal nerve. The superficials, here's a cryotherapy device in which I'm lesioning the nerves. This can work quite well for some patients. A lot of people are doing this preoperatively, but you can do it post-op. And I find there's usually 3 branches of the anterior femoral cutaneous nerve that you can get. The infrapatella has a superior and inferior branch, which is not always easy to distinguish, but many times you can see the bifurcation on the infrapatelosaphenous nerve. And then PNS, this is a great tool that we have now, and it's most likely working by a combination of peripheral and central pathways. The large diameter sensory fibers may directly engage the gate mechanism to decrease pain signals. Large motor fiber activation may be translated to physiological neural afferent signals that help gate or decrease pain. Decreasing pain signals over an extended period allows PNS therapy to possibly disrupt the cycle of centrally mediated pain. And this results in an activity-dependent neuroplasticity to maintain decreased pain long after the active stimulation period. I mean, I've seen these cases. I've even had a case where I did a trial for shoulder pain and it cured the patient after every nerve block and tendon injection I did failed. So PNS is here to stay. It's a great tool and it's pretty safe. So the sympathetic block, we're just basically using local to impede the nerve function. And it often involves monitoring the skin galvanic responses or blood flow to the extremity or temperature change that occurs. And it's, you know, it is different than doing a neurolysis. People do neurolytic injections of either phenol or alcohol of the lumbar sympathetic plexus. However, that's not as commonly performed. You could also use RFAs as well. Okay, well, thank you for hearing me out. I'm going to let you guys take over and go over the board review, CME tips, and trade secrets.
Hey, David, I had a question before you signed off. So did you guys ever think of doing DRG? Because, I mean, this patient sounds like a perfect DRG candidate for a really long-term solution for underlying pain.
I think that's where this was. I think I mentioned it to her, and that's where this was going if the sympathetic didn't work.
Okay. And so
Yeah.
is she coming back to see you?
She's doing better. So I haven't seen her in a few months, probably
Okay.
3 months ago, and yeah, she's doing much better, thank God. But she had a rocky road. It took us like a year to figure this out. So
Yeah. Well, I think, I mean, Melissa hit it really right on the head, right? Because, I think a lot of these patients take such a long time. And folks that are like post-amputee or post-surgery, CRPS, complex regional pain syndrome, causality, I mean, all of these things are things at some point we thought we couldn't help. And at least in my practice, we've seen a lot of success with DRG. And so, I think earlier in the algorithm, we can kind of move that therapy because, I mean, a trial is an early part of the therapeutic process. If they do well, then you can kind of escape a lot of those other things and just move forward. Well, thank you
It
so
looks like we
much.
have a
I think we have some questions.
Yeah, looks like we have a question from the audience here. They're asking can a variant of the QL serve as a psoas muscle diagnostic block?
I wouldn't call it, unless you're in the psoas muscle with a needle, I would not consider it. So, you might anesthetize part of the psoas muscle by placing your needle between QL and the psoas to get those nerves. But I wouldn't consider that diagnostic unless I either saw the needle inside the muscle under ultrasound or with a contrast under fluoroscopy. I don't know about you guys, but that's how I feel.
Yeah, I'd agree with that. I think if you're really going to try to diagnose the psoas muscle itself, you should probably have a needle in the psoas muscle. Versus the QL is helpful, not so much for diagnostic purposes, I think, so much as therapeutic for obvious reasons.
Yeah.
Perfect. All right. Thank you, Dr. Rosenblum, for all that insight and great tips and tricks on the questions that you saw in your real life patients and for all the panelists. So we're going to move on to the next part of our discussion, and really this is trade secrets and study tips, and what do you do in terms of preparing for boards? How did you kind of stay on top of that? And again, you got to remember that when training finishes, it's just the beginning of our education journey, right? I mean, we're really paving the way for the future of this field. It's no longer chronic pain management, but it's interventional spine. And so that's kind of where I wanted to, lead this discussion. We're going to basically open up to the panelists. So Melissa is the first person on my screen, and just kind of talk about, what her experience was, what she did to study, not only just for her boards, but how she's kind of keeping up with, the latest trends and staying on top of research.
Thank you. So I'm 4 years out. I will leave the board preparation to the younger ones. So I feel really old on this panel right now. So I think learning never stops, right? And it's something we learn every day, every week, every month in clinical practice, in day-to-day life. And I remember the first year out, I had this feeling of, oh my goodness, I have no lectures anymore. I no longer have a morning lecture from 7 to 8 every single morning. Someone will present me a slides or a topic to learn about. I don't have journal clubs anymore. I feel very lonely. Just I'm on my own. I have to figure out how to do everything on my own. So, and then I realized, there's so many mentors out there. There's so many opportunities. There are podcasts, there are webinars, there are meetings, and people to ask, and journals I can still read. So then I started to set a goal for myself. You know what? I'm just going to learn one thing a week. It could be as little as how to do a procedure, how to do a new physical exam, a new diagnosis, maybe a different way to make an incision, different way to close an incision, different way to communicate with a patient. It can be a number of things, but that's a path for continued education, self-improvement, is just keep learning. And that could be as little as learn one new physical exam a week, or learn new term a week, learn something different. So that way, each week we are getting better and better. Each month we're getting better. I think that way we can really continue to learn and keep up with what's new, because we all know in this field of pain medicine, there's so much going on. We have new evidence, paper, journal, guidelines coming out every month, and it's really hard to keep track of all that. But ASPN is a great resource with webinars, meetings and posts and podcasts. So I think that's one good way to learn, and also just communicate with people and talk to the peers, talk to your friends, and check guidelines from Medicare, from payers. And so recently, I'm sure many of you guys know that the genicular nerve RFA is no longer covered by most payers, which is really frustrating for many of us because we love doing that procedures and patients love getting that procedure. So things like that, we no longer have a lecture. We're not in fellowship. No one would tell us these things, but it's up to us to seek these informations and keep up with what's going on and just keep learning for the rest of our careers.
Perfect. Great job, Melissa. So we'll move on to Vinny. He's the next person on my screen.
Well, I'm in fellowship, so every day is learning. It's like drinking from a fire hose, you know. It's and I think it's human nature that you learn from your mistakes or for the things that you didn't do that well that you could have done better. So that's one of the things that I've really quickly learned within this year with fellowship. In terms of like board preparation, just like every day reading a little bit on something new that you saw in clinic or things that you are not familiar with, making sure that you're always focusing on the non-MSK spine stuff, looking at the abdominal pelvic stuff that we are talking about in our cases, and remembering your anatomy, kind of going back to dermatomes, nerve patterns, things like that. That is important to keep in mind. And try to sort of not be in a cruise control mode that you're like, oh, pain going down the leg into the foot, I'm going to do an L5S1 transforaminal. Think about like, what is the dermatome that's covering that area? What is my physical exam showing? And I think that helps not only you be a better physician, but also just keep those little clinical pearls and important aspects of your neuroanatomy that it's going to show up on boards always fresh in your brain. So that's like little things that I try to do, to just keep up with things that I don't forget. So that's what I try to do for board prep. Obviously, preparing for procedures. So if you have a case that you've never done before for one particular intervention, study the night before, look at all the different podcasts and YouTube videos that we have available for different societies. ASPN put excellent content with webinars, reviewing MRI procedures. We have an upcoming one with surgical technique. So there's so many different resources now. So just be as prepared as you can and ask questions. Every day ask questions from your attendees, from your mentors, from your colleagues, and try to every day, enjoy, number one, but number two, get something important every day and learn.
Excellent, Vinny. Thank you for the comment. So Anuj, the youngest of the youngins, what are your thoughts, man?
Yeah, absolutely. I think I agree with a lot of things. I think I want to make a comment about board prep versus an excellent clinician. Board prep wise, you have your Q banks, you're trying to pass an exam. And I think it's important to realize that going to conferences, ASPN or whatever conferences there are, you're seeing a lot of like the newest, greatest innovations and things that won't be really tested in that board prep. But to not stop your learning, like board prep will give you a foundation, or certain questions will only be asked in board prep that you don't really need to know or apply. So that may be separate, but just looking to be a better clinician and build off of the board prep itself, and not just get lost in the board prep. I think it's important, because that's how you continue to grow. And a lot of things that I've learned at a lot of the conferences I've attended probably won't be in my boards, which I'll complete the following year. But the cool thing is that I know that it's there, and I know how to build on the board prep that I did do and what's out there. And then the questions that I'll ask a lot of my mentors, a lot of people on this panel, and at these conferences itself, it's not good, may not be tested, but I will be a better clinician for it. So I think it's important to know that it's not just like don't drive it all on board prep, but there's a lot more growth outside of it too. So
all right, and then you, sir?
So I just took my pain boards 3 weeks ago, so still pretty fresh. I think when it comes to pain boards, obviously a lot of my co-fellows and I did a lot of question-based learning, and there's a lot of different Q banks out there. There's a lot of different question books out there, and so we just kind of asked our more younger attendings what they used, and everyone used different resources. The thing with pain boards that's different than the other subspecialties is that it's quite multidisciplinary. So there are quite a few I'm anesthesia background, but PM&R questions, neurology questions. There were quite a few psych questions. And I think a lot of what I learned during my fellowship, especially during my rotations that were off-site rotations, non-pain rotations, was really helpful. And I was able to answer a lot of the questions, again, based on just me looking things up that I didn't know. So the first time I saw thoracic outlet syndrome, I looked it up, I searched it, and there was a ton of questions on that. So I think, again, kind of like Kanuj said, you follow the textbooks and you follow that, but it's really the day-to-day learning. And then just to piggyback off of what Melissa said, I've been in attending for less than 2 months now. It is every day is a whole new day of learning, but I think setting a realistic goal of one thing to learn a week is really, really helpful, just so you can stay in the loop. And whether that's reaching out to mentors, I still reach out to my mentors for my fellowship, mentors that I work with, but also lateral mentorship. So I have a small group text with a few of my co-fellows. Each one of us is in a different based practice setting, but we're all asking each other questions, learning from each other's mistakes, sending articles to each other. So keeping in touch with your co-fellows too, and having that lateral mentorship also is very, very helpful.
So I have a question for all of you guys. So it's great to keep learning, do questions, and just keep learning. How do you find time to do it? We're working all day, 8 to 5 or 7 to 5, and you see 40 patients a day, you have 30 procedures, you're home at night, you're exhausted, you have family to take care of, I have to cook dinner and clean the house. How do we find time to do this?
I think part of it is, I think the tough part is, I always remember in residency and fellowship, you had an obligation to study, right? And there was time built into the schedule for you to either get lectures, as you had mentioned, Melissa, or even, like sort of throughout the week, there was just downtime when you could. That really doesn't happen in your own practice, where hopefully you're busy, you're seeing patients, and just as you mentioned, there's so many things in your own personal life you need to be taking care of as well. I think that makes it tougher because now the onus is on you to learn. One thing that I have found helpful is however you can incorporate that learning into your actual practice, right? So if you just think of your own patient who you saw in clinic, right? And perhaps you're trying to figure out, okay, what can I do a little bit differently? Or what are you a little bit perplexed about? Or what is something that you're really not as familiar with in regards to this patient's case that you could brush up on a little bit, right? Well, now if you just take about 15, 20 minutes, right? Maybe during lunch or whenever to study for it, you're learning, but you're also really just trying to figure out what you're going to do about this patient, which we're going to do anyways, right? So however you can incorporate that. The other thing that I've actually found very interesting and helpful, which I wasn't anticipating, was in my previous job, we hired an APP, and she was excellent. She had a lot of experience in cardiac surgery, but no experience in pain. So I had a teacher. She was super willing to learn, but I had to sit there and teach her pain. So when I did that, I had to come up with lectures and things like that, and we went over different topics every week. And in doing so, I was kind of refreshing my own memory of some of the basics, right? I mean, I know how to do a kyphoplasty. I know the fundamentals of, vertebral compression fractures, but it's very different when you have to teach that to someone who doesn't know those things, right? And so I think that was a way in which I was able to incorporate that into my just, hey, I have a new APP, I got a teacher, now let me, brush up on some of that stuff myself as well.
So Nasir, you make really a great point, because it's hard to fit in all this information, right? And what I try to do every time I have new patients coming in, I try to look at what kind of patients I'm going to have the day before, and if there's something unique that I'm getting a referral for, I try to read up on that. But another teaching moment is when you're actually teaching and educating the patient, right? Because it's one thing you're educating your peers, but you really know what you're talking about when you understand that the patient understands what you're talking about. And I think that's, for me, Dr. Tim Deere taught me this. Like, we have a whiteboard in our clinic. And so I kind of draw out, what my algorithm is, right? I kind of draw out the anatomy of where I think the problem is. And I try to explain it in the patient's understanding. And so it may be something new, maybe some of the things we covered today that we don't always see. But I think that it's educating and brushing up on those things on a daily basis. And it's not about just, well, how do you find time, right? Because medicine is an art. But a lot of people just become passive, or like many said, they just become on autopilot and they kind of forget about that. But that's a disservice not just to us, it's a disservice to our profession, it's a disservice to our patients. And for us, I mean, we're the leaders in this field for a reason, right? We're the innovators for a reason. We're blessed to be in this opportunity, but it's also on our shoulders to brush up on the newest things, to keep up with that. And not just about learning the content, but also being proficient with the procedures. And so the next question really is, how do you guys keep up on those skills? Because a lot of the things we're doing now, right, like lumbar decompressions or posterior SI fusions, these things weren't really taught in fellowship, right? And they're not really taught in the chronic pain management atmosphere because it's beyond pain medicine at this point. So, kind of basically, let's go across the board and talk about how are we brushing up on those things and how are we keeping those skills up so that we can provide those patients that care that they need now.
Yeah, great question. We don't always have time to travel for cadaver courses, even though there are a lot of them available throughout the country every year. But it's important to find these little opportunities here and there. So that could be watching a webinar. Like, I think there are a few hundreds of you guys right now watching this webinar, and I'm sure you're not just sitting in front of your computers. Many of you probably in the gym working out. Many of you probably either you're cooking or you're driving or you're doing other things. But hey, you're locked on and you're listening, you're learning, you are continuing your education. And I find myself doing the same thing. I'll be bathing my kids and I would have my headphone in and I would listen to a webinar and I can learn a different decompression technique, a different some new things out there. So I would say grab any opportunity you can find. And I think webinar is a great way that it's something easy that you can just put your headphone in, even if you're just driving or doing other things. If you do get the opportunity to go to a conference and go to a lab, you can actually put your hands on these equipments and actually learn it. And if you do get invited to go to different things, I will go. It is a commitment to be away from your family for the weekend and just to go to a different place just to learn a new technique, but it is so worth it. And it truly opens up your eyes to what we have to offer to our patients. So it can be as little as just webinars here and there and going to conferences, go to courses, and actually put your hands on those cadavers, on those equipments to truly keep up with what's going on.
You, sir?
Yeah, so I make an effort to go to cadaver courses, especially to get exposure to therapies I didn't get to in fellowship. So just actively seeking out reps or territory managers in my area, reaching out to them, making sure that I can go to these courses and get certified so that I'm able to offer this therapy. One thing I do is I get the neuromodulation journal home, sent to my house every month. I try to make a point to at least read one article out of it every month. I tend to save my time to read or learn towards the end of the night, just give it 30 minutes one day of the week. And like you guys mentioned, if I have a little bit of time in during my clinic day when I'm seeing patients or I have a no-show and there's something that I make a note of that I wanted to read about specifically for another patient, I'll just sit and read about it. So you find these little pockets of time throughout the day to do it, but I dedicate at least one day of the week, 30 minutes to sit down, read something new. And then outside of that, going to cadaver courses, making sure I go to conferences, making sure I'm able to listen to all of these webinars. Again, I think being an attending is really the start of learning, and it just continues throughout.
Excellent.
I
So,
completely agree with.
Sorry, go
I
ahead,
completely agree with all those things. I just wanted to say one thing, especially Vinny and Anuj, you guys are residents and fellows and stuff like that. And so, I guess the point that I want to make, just because I think everyone found out, was it last week or this week, when where they're going for fellowship, right? And so, that's a time that's really, there's a lot of emotions with all that, right? It's like, oh my God, I matched at, where I really wanted to go or where I didn't want to go. And, me and Vinny are, we're trained and training at the same place, right? And so that's a place where we get a lot of exposure to really kind of, cutting edge therapies. But you know what? There's a spectrum of fellowships out there. And the point that I want to make is where you go to fellowship has little to do with your long-term success, because the onus is on you individually to either capitalize and leverage that training that you did get in fellowship if you went to a place where you were fortunate enough to get a lot of exposure to advanced therapies, or to then take advantage of as many industry or society courses as you can during fellowship, because you may not be getting that in your day-to-day, and then continuing to do that in your own practice as well. And I know a lot of people who went to fellowships where they really didn't do that many stimulators or advanced procedures at all, but they're really doing a lot of them in their own practice because they've made it a commitment to themselves and to their patients. They're really going to learn those things. And then similarly, I know people who went to fellowships where, you know, they did a ton of, you know, kind of advanced procedures, and they got very proficient with it, but they just didn't continue that down the road. And unfortunately, because of that, they really are not able to kind of continue to provide those therapies to their patients. So don't be discouraged, and don't be overly, you know, happy either way, just because there's a long road ahead, and just be persistent, and that always wins out at the end.
Perfect. Well said, Nasir. So I think, I mean, we're going to begin like the conclusion of, you know, this webinar tonight, since we're almost out of time, and I appreciate everybody joining us, especially Dr. Rosenblum for putting that great presentation together. So one thing is, you know, I think all of us, you know, we've persistently stayed involved. And that's a big part of, you know, not only acquisition of information, but also sharing that information with others, right? Kind of like Melissa and Yusuf touched on, right? That, you know, we have different experiences where we end up, but it's kind of staying in touch with your co-trainees or the relationships you build at these national conferences. I think that helps pay that forward. So one of the things, you know, that ASPN has really done a great job on, both Nasir, myself, and Melissa have been really blessed to be part of, was, you know, the Poster to Podium program. And so this coming year, we're actually kind of splitting that into two tracks. And so one of the tracks is going to be the Young Innovators track, which, you know, some of the folks that are involved, I think, got an announcement, you know, last week. But I just really wanted to, you know, give a shout out to, you know, all the folks involved in that, because it's such an important opportunity, because research drives our field forward, right? Remember that we are innovating this field, and it's not what it was, you know, when our mentors even got trained. Right? Our mentors are leading the way, but we have to kind of step up. And so I really want to encourage people that, you know, the folks that you guys know around you, the folks that may not be involved as much, give them an opportunity, try to get them more involved, because ASPN has a lot of resources that are available. You know, this is just one of many of those resources. And yes, you know, you need to get trained, you need to get that core content down. But at the end of the day, it's solving these bigger problems for our patients. The only way we can do that is really forming this community and relying upon one another here to drive it forward. Nasir, you have anything else left?
I completely agree.
All right, guys, I think we have two quick slides, and that's it, guys. And then hopefully we'll connect in a couple weeks.
Be sure to claim the CME credit, by the way.
Yep, absolutely. So I just want to make a comment on the CME portion. You know, again, thanks to Dr. David Rosenblum for helping facilitate that. You know, our goal is to really help transition this from, you know, being just educational information to more CME-based information. So that one, it benefits our attendees in multiple levels, but also it kind of strives to a higher standard. And so we're going to try to incorporate that, you know, moving forward. So next week, you know, I think there's a really great webinar coming up. And again, you know, like we talked about, you can listen to this, you know, while you're driving or while you're running. But, you know, surgical technique and wound healing, this is a really big part of, you know, what we're doing, because we're becoming more and more interventional spine. And so I hope everybody gets a chance to attend that next week. So we have a following webinar. It's on informed consent. So informed consent really is a unique platform. We're beginning to pilot it in our own practice. And you guys are going to really get a good insight on, you know, how this works, and to better educating our patients about, you know, the procedures that we're doing. And it's a really unique app-based platform that not only tracks their eye motion as they're viewing that informed consent guidelines, but at the same time, it kind of helps to further answer their questions. I think Dr. Tim Deere is leading that at the end of the month, and we'll get some more insight on that. So I think that's our last slide. One thing is, you know, Dr. Rosenblum was, you know, gracious enough to put some bonus content in terms of questions together. And so that should be available in a PowerPoint format, both on our website and on the Pain Exam website as well. And then the final thing is, you know, for all of those that are attending, please just, you know, reach out to us, because we're working to redo that website for the Young Innovators, which are going to have a more advanced landing page to kind of get you guys more involved. Thanks, everybody.
Thanks, guys.
Thank you.
Thank you.